Surgeons have a name for what happens to the brain after surgery in older adults. They don't always say it out loud. They don't always put it in the consent form. But in operating rooms and intensive care units and quiet hospital corridors, they know it exists. They call it the quiet brain cost. And after years of watching older patients go through surgery, I can tell you with certainty that this is the conversation most families are never given before the operation is over. Not because doctors are hiding something, but because everyone is so focused on fixing the body that nobody stops long enough to ask what is happening to the mind today that changes. Because if you are over 70, or if you love someone who is and surgery is on the horizon, there is a question you need to carry into that consultation room. A question that most people never think to ask. A question that could genuinely shape what life looks like on the other side of the operating table. And before I give you that question, I want you to picture something with me. Not the surgery itself, not the hospital room, not the monitors or the gowns or the sterile lights above the table. I want you to picture the days that come after. Picture sitting at a dinner table with the people you love most, the people whose faces you have known for decades, and feeling like the conversation is moving slightly faster than you can follow. You reach for a word and its lips. You look around a room you have lived in for 30 years and something about it feels unfamiliar in a way you cannot explain. You wake up in the middle of the night and for a few terrifying seconds you do not know where you are. You try to tell someone how you feel and the sentence does not come out the way you meant it. You stand up and your balance does not feel like your own. And somewhere in the back of your mind, underneath the confusion, there is a single quiet question. Why don't I feel like myself? This is the part of surgical recovery that nobody prepares families for. Not because it is inevitable, not because it happens to everyone, but because when it does happen, when the person you brought into that hospital comes home and something in the mind seems slower or hazier or further away than before, most families are blindsided. They assumed that if the surgery worked, the person would come back whole, and sometimes they do. But sometimes the brain needs its own recovery plan, and if nobody built one, the results can be heartbreaking. Here is what most people don't realize. Anesthesia is not just one switch with two positions. It is not simply awake or deeply unconscious, and the brain's recovery after surgery is not shaped by one drug or one decision. It is shaped by the total weight placed on an older brain from the moment preparation begins to the final hours of that critical first week. And if you understand how that weight accumulates, you can do something about it. That is why you are still listening. Let me tell you about a man I want to call David. He was 74 years old. Sharp, engaged, the kind of person who read 2 newspapers a day and argued about current events at the dinner table with a precision that made his grandchildren roll their eyes affectionately. He needed hip replacement surgery, routine procedure. His surgical team was experienced. Everything about the operation went exactly as planned. Stable vitals, clean closure, no complications on paper. 3 days later, his daughter walked into his hospital room and he looked at her from the bed with eyes that were open and awake and still somehow not quite present. He asked her what city they were in. He asked her twice. He thought it was a different year. He kept mentioning a colleague from a job he had retired from 15 years before, as though that man had just called on the phone. The daughter stood at the bedside and felt a fear she had never felt before. Not the fear of losing him, something stranger than that. The fear that he was still there, but something essential had slipped. His surgery had been a technical success. His hip was repaired, his body was healing, but his brain had entered a state that nobody had warned his family about, had not given them any tools to recognize, and had not prepared them to navigate. And what his family did not know then, what they wish someone had told them before that operation was scheduled, is that what they were watching had a name. It was called postoperative delirium, and it is far more common than most people realize in some surgical settings and among patients over the age of 70, studies have found that postoperative delirium affects anywhere from 20 to 40% of patients. In cardiac surgery populations and hip fracture repair, those numbers in higher risk groups can climb even further, 1 in 3, sometimes more, and yet the majority of families going into those procedures have never once heard the word delirium mentioned in a pre-surgical conversation. Delirium is not simply confusion. That word makes it sound gentle, manageable, like a mild side effect that passes before breakfast. What delirium actually looks like in an older adult after surgery is something far more disorienting for everyone in the room. It can look like agitation, like a person who is normally calm becoming suddenly restless or combative. It can look like hallucinations, seeing people or objects that are not there with complete certainty that they are real. It can look like severe disorientation to time and place, believing it is a different decade, not recognizing family members, not understanding where they are or why. It can swing rapidly between these states and a kind of excessive drowsiness that makes the person almost impossible to rouse. 1 hour the patient is calling out, the next they cannot keep their eyes open, and underneath all of it is a brain that has been pushed past its margin and has not yet found its way back. This is where things start to change in a way that deserves your full attention, because postoperative delirium is not just a temporary fog that always lifts cleanly. For some older adults, it marks the beginning of a longer trajectory. Researchers have a term for what can follow. They call it postoperative cognitive dysfunction, often shortened to POCD. And while not every patient who experiences delirium goes on to develop POCD, the connection between the two is real and documented and deeply important for families to understand. Postoperative cognitive dysfunction is a condition in which memory, concentration, processing speed, and executive function remain measurably below the person's baseline weeks or even months after surgery. Not dramatically, not always in ways that are obvious to a stranger, but in ways the family notices. The person who used to handle finances now finds the numbers slippery. The person who used to follow fast conversation now asks people to repeat themselves more often. The person who used to navigate independently now seems less confident in unfamiliar settings. These changes can be subtle. They can also be the beginning of a steeper decline in someone who was already on the edge of cognitive vulnerability. I want to be careful here because this is a place where fear can easily outrun the facts, and that does not serve anyone. Not every surgery causes lasting cognitive effects. Not every older adult who undergoes anesthesia experiences delirium. Many people in their 70s and 80s go through complex procedures and come through them with their minds fully intact. The goal is not to avoid necessary surgery. The goal is to understand the risk well enough to protect against it intelligently. And that begins with understanding why the older brain is more vulnerable in the first place. The concept you need here is called cognitive reserve. Think of it this way. Every brain has a kind of internal buffer, a surplus of processing capacity and resilience that allows it to absorb disruptions and bounce back. In younger adults, that buffer tends to be wide. The brain can handle the chemical and physiological disruptions of surgery, metabolize the medications efficiently, manage the inflammation and pain and sleep disruption, and still find its footing relatively quickly. In older adults, that buffer can be narrower, not because the person is intellectually diminished, not because they are fragile in a global sense, but because the brain, like every other organ in the body, changes with age in ways that affect how it tolerates extreme disruption. The liver may metabolize anesthetic drugs more slowly, so they stay in the system longer. The kidneys may clear them less efficiently. The blood vessels that supply the brain may be less forgiving when blood pressure drops during a procedure. The receptors these drugs act on may be more sensitive in later life, and the brain's natural recovery mechanisms, the ones that quietly restore normal signaling after any disruption, may simply need more time and more support than a standard recovery plan provides. This does not make surgery impossible or even inadvisable. It makes thoughtful surgery a very different thing from automatic surgery, and it makes the question of anesthesia approach far more important than most patients and families ever realize they are allowed to ask. Here is what most people don't realize. General anesthesia, the kind in which a person is rendered deeply and completely unconscious for the duration of a procedure, is sometimes the only medically appropriate choice. There are operations that cannot safely be done any other way, but general anesthesia is not always the only option, and for older adults with narrower cognitive reserve, there are alternatives that may place significantly less stress on the brain. Alternatives that exist, that are used regularly, that are sometimes better suited to certain procedures and certain patients, and that most patients and families never know to ask about. Let me walk you through 4 of them. Not with medical jargon, but in language that actually helps you picture what each one means. The first is called a peripheral nerve block. Imagine you could silence a specific region of the body for the duration of surgery, the way you might turn off sound in one room of a house while leaving every other room completely functional. A peripheral nerve block does exactly that. The anesthesiologist uses a carefully placed injection near a specific nerve or group of nerves to numb only the area of the body involved in the surgery. For a knee procedure, for example, the nerves serving the knee are blocked. The patient remains awake or receives only very light sedation. To stay calm and comfortable, the brain is never chemically suppressed. It never has to fight its way back from deep unconsciousness. Recovery of alertness is far more immediate, and for a significant number of surgeries, particularly in the limbs and extremities, a peripheral nerve block is a completely viable and medically sound approach. The second alternative is epidural anesthesia. You may have heard this word in the context of childbirth, but it applies far beyond that. An epidural involves placing a very thin catheter into the space just outside the spinal cord, through which anesthetic medication is carefully delivered to numb a broad region of the body, typically from the waist downward. Unlike general anesthesia, the brain remains entirely conscious throughout. The patient is aware, can communicate, can answer questions, can tell the team how they feel. The surgical field is numb and pain-free, but the mind is not suppressed. For procedures in the lower abdomen, the pelvis, the hips, or the lower extremities, epidural anesthesia can be extraordinarily effective and is routinely used in settings around the world as an alternative to general anesthesia. The third is spinal anesthesia, which operates on a similar principle. A single injection into the fluid surrounding the spinal cord delivers anesthetic medication that produces complete numbness from roughly the waist down. It takes effect quickly, lasts for a defined period, and like the epidural approach, keeps the brain fully conscious and active throughout the procedure. Many hip replacements, knee replacements, and abdominal surgeries have been completed successfully under spinal anesthesia. It is not a workaround or a compromise. For the right patient and the right procedure, it is simply the more brain-sparing option. The fourth alternative is conscious sedation combined with local anesthesia. This approach uses a mild sedative to keep the patient calm and relaxed, while local anesthetic numbs only the precise area of tissue being operated on. The patient is not fully unconscious. They may drift into a light, comfortable drowsiness, but they retain the ability to respond, to breathe independently, and to maintain their own orientation. The brain is not chemically suppressed at the same depth as in general anesthesia, and recovery of full clarity is often faster and more complete. These four approaches are not experimental. They are not last resorts. They are established, practiced, and frequently used by skilled anesthesiology teams around the world, and the fact that most older patients never know to ask about them is one of the most consequential information gaps in surgical preparation today. And this is the part no one talks about. Choosing a brain-conscious anesthesia approach is not about distrusting the surgical team. It is not about fear. It is about entering the operating room as an informed participant in your own care. Because here is what thoughtful anesthesiologists already know. Age is not just a number on a chart. It is a variable that shapes how every drug behaves, how every disruption is tolerated, and how every recovery unfolds. When a patient walks in and shows they understand this, the conversation does not become adversarial. It becomes more precise. And more precise conversations tend to produce better outcomes. So let me give you the exact sentence you can take into that consultation room. Say this, or something close to it, to your anesthesiologist or surgeon before the date is finalized. Given my age, I want to make the safest choice for the surgery and also protect my mental clarity afterward. What is the lightest effective anesthesia plan for me, and are there regional or lighter sedation options that fit this procedure? That is it. 12 words of context and one clear question. It tells the team that you are thinking beyond the procedure itself. It invites them to share options they might not have brought up otherwise, and it reframes the entire conversation from what must be done to your body to what can be protected in your mind. If the answer is that general anesthesia is still medically necessary for your specific case, ask one follow-up question. What makes full general anesthesia necessary in my specific case? Not as a challenge, as a legitimate, responsible request for information that you deserve. Any good medical team will welcome it. But anesthesia approach is not the only variable, and this is where families often make their most costly assumption. They assume that once the surgery is done, the hardest part is over, that recovery is just a matter of time. But for an older brain, the first 72 hours after surgery may actually be the most critical window of all. This is when medications are still being metabolized and cleared. This is when pain levels are highest and opioid medications are most likely to be used. This is when sleep is most disrupted. This is when the body's inflammatory response is at its peak, and this is when the conditions for postoperative delirium are most perfectly assembled. Everything stacks on top of everything else. Pain leads to more medication. More medication dulls the senses and clouds orientation. Poor orientation increases anxiety. Anxiety prevents sleep. Poor sleep lowers the pain threshold. A higher pain threshold requires more medication. The loop closes on itself. Here is what most people don't realize about that loop. It can be interrupted, not by dramatic intervention, but by small, deliberate acts of brain protection that compound in the same way the problems do, only in the other direction. Getting glasses and hearing aids back on as soon as possible after surgery does more for orientation than most families expect. The brain relies on sensory input to locate itself in time and space. When vision and hearing are impaired, the world becomes strange and unreadable. Simple sounds become distorted fragments. Familiar faces become blurry abstractions. And an already stressed brain cannot afford the extra work of trying to interpret a world it can barely perceive. Returning those sensory anchors is not a small comfort. It is a neurological intervention. Getting the person upright and moving, even briefly, even gently, matters more than keeping them still in the name of rest. Movement stimulates circulation. It promotes deeper breathing, which improves oxygen delivery to the brain. It reactivates the bowel, which has often been slowed by opioids and immobility. It signals to the nervous system that the crisis is over, that the body is intact, that life is continuing, and the brain, which is always reading the body for information about the state of the world, needs that signal. Maintaining a consistent day-night rhythm, dimming lights at night, allowing natural light during the day, reducing unnecessary noise, keeping clock and calendar visible, orienting the patient to the day and the place and the people in the room. These are not soft, decorative gestures. In clinical settings designed around these principles, rates of postoperative delirium have been shown to fall significantly. The brain responds to structure. It recovers faster in environments that make orientation easy rather than effortful. And then there is medication, not the medications used in surgery, but the ones waiting on the bedside table at home. Before any procedure in later life, a careful medication review is not optional. It is essential. Certain antihistamines commonly used for sleep, certain bladder medications, certain antidepressants, certain anti-nausea drugs. These belong to a class of compounds that block a neurotransmitter called acetylcholine, and in older adults, they can significantly amplify cognitive vulnerability. They are called anticholinergic drugs, and many of them are available over the counter. Many older adults take them without realizing the cumulative impact on brain function, especially when surgery adds a second and third layer of chemical stress on top. I want to return to David for a moment, because his story does not end in that hospital room. 3 weeks after surgery, with his family watching closely and his team providing support, David began to come back. The disorientation lifted slowly, like a fog burning off in the morning. His sentences became cleaner. His eyes became more present. He started asking about the news. He started arguing about politics at the dinner table again, tentatively at first and then with his old confidence. By 6 weeks out, he was largely himself. His family exhaled, but they also carried something forward from that experience. His daughter told me afterward that she would never again go into a surgical procedure for any older member of her family without asking the question, without bringing the medication list, without packing the glasses and the hearing aids, without understanding what the anesthesia plan was and whether a lighter option had been considered, because she had seen what happened when those conversations did not take place, and she never wanted to stand at a bedside again wondering whether the mind she loved was going to find its way back. That is the shift this conversation is trying to create. Not fear, preparation, not suspicion of the medical system, partnership with it, because the doctors and nurses and anesthesiologists who care for older adults in surgery are, in the vast majority of cases, doing their best with the information and the time they have. But the patient who walks in already knowing what questions to ask gives that team something invaluable: the opportunity to be more precise, the invitation to slow down for 30 seconds and consider whether the standard plan is also the optimal plan for this specific person on this specific day. Standard care is not bad care, but individualized care, thoughtful care, brain-sparing care is better. And the only way to access it reliably is to ask for it by name. There are 3 things you can do this week regardless of when surgery is coming. First, write down every medication, supplement, and over-the-counter product the older adult in your life takes regularly and bring that list to every medical appointment. Second, if any cognitive concerns already exist, even mild ones, make sure the surgical and anesthesia team knows about them before the procedure is scheduled. Cognitive vulnerability that exists before surgery is a predictor of how the brain may respond to the stress of surgery. It does not disqualify anyone from getting necessary care, but it should absolutely inform the plan. Third, have the conversation. Not after the consent forms are signed, before. Ask the question. Say the sentence. Make the brain part of the plan, because here is the truth that every family deserves to hold before they walk into that hospital. A successful surgery is not measured only in clean margins and stable vitals and a body that heals. It is measured in what comes after, whether the person who went in comes back, whether the eyes are clear, Whether the words come easily, whether the mind that has navigated 80 years of this world is still navigating it on the other side of the operating room doors. That is the real outcome. That is the measure that matters to families. Not a surgical report, not a set of numbers on a discharge form, but whether this person, this irreplaceable, specific human being, can still sit at the table, join the conversation, remember what day it is, and feel present in their own life. The brain that goes into surgery deserves its own protection plan, not as an afterthought, not as a secondary concern, but as the central question, asked early, asked clearly, and answered in full, before any surgery in later life. Ask not only what will be fixed, but how the brain will be protected while it is being fixed. Ask about anesthesia options. Ask about blood pressure and oxygen management. Ask about the plan for the first 72 hours. Bring the glasses, bring the hearing aids, review the medications, watch the recovery closely, and trust yourself if something about the person in front of you feels mentally different from who they were before. The people who know the patient best are almost always the first to notice. The brain changing, that instinct is data. It should never be dismissed. Pass this along to someone who needs it before an operation, not after one. A parent, a spouse, a sibling, a friend. One conversation before surgery can spare a family a great deal of confusion and grief afterward, and every older adult facing the operating table deserves to enter it knowing that their mind is being protected with the same intention as everything else, because a successful surgery is not just about fixing the body. It is about coming back with your mind still intact.